5 years ago, my mother-in-law, who's no longer with us, unfortunately, had to visit my father-in-law, who was having heart surgery in VCU. She did drive at night, and it was a difficult task getting her there in the parking lot and the whole deal. The point of the story is that it was really difficult for her to go visit my father-in-law in the ICU or the CCU in Williamsburg. So I thought to myself, do people leave Williamsburg to get total knees and toes because they have to, or do they leave because they want to? And I think over the last 4 or 5 years, and our progress has kind of demonstrated that people really kind of leave Williamsburg because they have to. But now that we've got a great partner with Centera Hospital and our group, we've really changed the way total joint arthroplasty care is delivered in Williamsburg. So that having been said, let me go over some slides. At any time, please just stop, ask a question. I don't want to get too detailed because we get lost in the weeds. So if you have any question whatsoever, just stop. If you want to ask a question now, or even something that's not even related to the slide on the screen, that's fine too. I want this to be as open as possible. This is more for you, it's not for me, because I kind of know what's on the slides. So, fundamentally, osteoarthritis, what is it? It's the gradual wear of the cartilage that covers the ends of the bones over the course of decades. You typically don't see it in 40-year-olds, you can with rheumatoids, but the older patient or the more mature patient tends to get the osteoarthritis, and there is a genetic component to the development of osteoarthritis. So this is kind of an interesting picture. So when you go see your doctor and you say, why is my knee looking so bad? Well, if you look at this, if you look at this interval right here, that blue line, what you see, this is the femur above, that's the kneecap in the middle, and this is the tibia below. So the space in between is not space, it's filled with cartilage. The x-rays go through the cartilage and come off the bone. So what you're seeing on the bones, what you cannot see is the arthritis. Key thing to remember is that cartilage does not have nerve supply, nor does it have a blood supply. And that makes a big difference in how we treat arthritis. You'll see some treatment options further down the road that some will work and some won't work. So remember, you want to see a lot of black between the ends of your bone. If you don't see black between the ends of your bones, you're getting in trouble. So here's another x-ray. And over here you see there's very little black space between the two surfaces of the bone. And this one's kind of falsely elevated because this leg is deformed because of the weight-bearing surface. And then if you look inside the joint, which you see here, this is an old worn-out piece of meniscus. And then you see just a little bit of cartilage right there where that blue line is pointing. And the rest of this is a purely arthritic joint. The knee joint has no cartilage covering it. So what you see is exposed bone. Now bone, on the other hand, has nerve endings. So when you wear off all the cartilage off the ends of the bone, when you get off the end of the bone, the femur and the tibia, you have exposed bone, which is a source of pain. Okay? Nerve endings, blood supply, cartilage. So thank God we don't have nerve endings in arthritis, because right now when we were 20 and everything, if everybody had nerve endings, we'd all have pain all the time. So this is important. This is an important concept. Remember the x-rays, bare bone, that meniscus, we're not going after that meniscus. Because if I do, I'm not going to do you much good because you still have to deal with the pain. Now here it is in the hip. Now if you look at this hip, you see that the purple line, where we see that white margin, that's called sclerosis. That means that this individual's been wearing down that bone for a long, long time. There's no cartilage between the head of this femur, which is this bone right here. So this is the femur, and this is the cup. And you can see that head has got all these changes, and so does the acetabular, or the cup side. They both have big holes in them, and those holes are generated because the synovium tissue that lives in the joint has gotten into the bone and started to eat it up. Okay? So sooner or later this guy's going to collapse, but fortunately we got to this and did a total hip before he got into serious, serious pain. We good so far? Yes. All right, good. So let's move along. Now, the characteristics of osteoarthritic pain. Do you have stiffness in the morning after prolonged activities or pain with weight-bearing activities? These actually are arthritic pain. That's the bone rubbing on the bone. That's what causes the stiffness. That's the mechanical pain. I want to call that the hard tissue pain. Because what you're doing, you're stimulating those nerve endings at the end of the bone. Okay? Hard tissue pain. Do you have nighttime pain? of pain at the end of the day. This discomfort represents a synovitis. What is that? There's a tissue in joints that have cartilage. Cartilage does not have blood supply, so it has to have some form of nutrition. The form of the nutrition is synovial fluid. The synovial fluid comes from the synovium. The second job of the synovium is to remove debris from the knee. Now, there's not too many young kids in this room tonight, so, except for the two in the back and the one running the camera. Their synovial fluid is recycled every 6 or 7 days. Those of us, the rest of us, our synovial fluid is recycled every 3 or 4 days. So that tissue, it gets more active. When it has to eat or take care of pieces of cartilage that we knock off from the ends of the bone, that also adds to the hard work that the synovium has to do, and it develops synovitis. Itis is Latin for inflammation, so you get synovitis. That we're going to call the soft tissue pain. So now we know that if you have mechanical pain, that's your arthritis. And if you have this nighttime pain, or why do I have pain at night when I'm not doing anything? It's because that synovium is inflamed. That's soft tissue pain. Okay? Yes, sir.
So you can have both.
Oh, absolutely. Absolutely have both. Absolutely. In fact, most people do by the time they get to come and see us. So now then, let's say, do you have to hold on to the handrails to negotiate stairs? So that's beginning to tell me that you're having weakness. And in particular, you're having weakness of the quadriceps muscle. The quadriceps muscle, you'll see, is the most important muscle to be able to walk. You've got to have a good quadriceps muscle. And if your joints are going bad, you're not getting the range of motion, so you're not putting that muscle at full stress, so it becomes weak. So now you're going to have hard tissue pain, you're going to have soft tissue pain, and you can have weakness. Now you're getting into trouble, okay? Then finally, if you have difficulty getting out of a car, if you can't put on your socks, then you're going to have loss of motion. Was there a question? Yes, ma'am.
Does physical therapy help this stuff? Is that one way of helping it?
That's a very good question. And in fact, there's 2 slides that talk about physical therapy with regards to what we're going to do. And that's a good question. No. So now this guy can't put on his socks. So if I'm standing and you come to the office and you've got bad hips, I'm going to ask you to kind of just cross your leg like that. If you have a bad hip, you cannot do that. You just cannot. You can't make a figure 4 with your legs. Okay. If you can't get that leg all the way down. Okay. Or it hurts. It hurts. Okay. So that's just one easy thing. Put on your socks. Get out of a car. Because to get out of a car, you got to have good motion in your hips and your knees. So that's loss of motion. How far can you walk without pain? If you can't walk very far, then you've got endurance problems. You can't. Your muscles aren't working. Your joints aren't working. Now you're in trouble. So you've got nighttime pain. You have daytime pain. You have loss of motion. You have weakness, and you have lack of endurance. So now things are really starting to add up. So the question comes to mind is, can I wait too long? And the answer is yes. You can wait too long. Truly, 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 in today's age, with the kinds of implants that we have, with the kind of techniques that we have, if you can come to us earlier than when it's all deformed and you have no endurance because your quadriceps is weak and you don't have the strength and you can't get up and down the stairs, maybe it's too long, so we got to do more dissection, different kind of bony cuts, and your rehab is going to be much slower. So there is such a thing as waiting too long. Okay? And let's face it, those of us in this room, except for those other exceptions, we got to think about what kind of lifestyle do we want to have? What we want to be able to go on a holiday. We really want to be able to have playing with the grandchildren, do what we want to do. Because if we can't do that, life just really changes dramatically, in my opinion. So, to answer the question earlier, most people have both hard and soft tissue pain, and the nighttime pain is usually the life changer because now you kind of sleep, and you get into the sleep cycle that just becomes worse and worse and worse and worse. And so then you find, well, I can't, and the wife is complaining, or the husband's complaining, and they say, but that's why they're there, to make sure that all the complaints get aired out with me before they leave the room, to make sure everybody understands where we really are with this knee, where this hip. So, what can you do? Clearly, weight makes a difference. If BMI greater than 25, we ask these folks to kind of lose weight. There's another number that's gonna show further down the road. The 25 is like ideal, but let's be honestly real. The last year, the average BMI for all the joints we did at Central Williamsburg Hospital was 33.2. So these aren't small people, okay? We don't see very many 25s, okay? The average was 33.2. Weight loss has a definite improvement in the function of the joints, especially knees and the hips. Okay, so weight is a definite contributing factor to osteoarthritis. And even more, yes ma'am, a question?
I didn't mean to interrupt in the middle of your sentence. But once you're bone on bone, how much does the overweightness have an impact?
Well, that's a good question. Once you're bone on bone, it's not gonna make a huge difference. It's a huge difference, but there is a number coming up that's gonna impact what happens to somebody's, potentially happens to somebody's knee. The other thing to remember too is that if you look at a knee, the medial femoral condyle is longer than the lateral femoral condyle. Okay, so when people come to the office, most of the arthritis is on the medial side, and that leg goes like that, bends to the inside. It goes like bends to the inside, so you're like this. So it does make a difference. But now when you have that extra weight, bone on bone, then you increase the deformity of your knee even more and more and more, and then the soft tissues change. And then that's another additional part of the operation that we have to pay closer attention to. Okay, so it does make a difference. So, low impact aerobic activities, walking and cycling. Quadricep strengthening is not only suggested, but now I would say it's probably very good to almost mandatory, particularly if you come in and you're looking a little weak. Quadricep strengthening is the most important thing. An easy way to do that is to ride a bicycle with the seat up high, because that way you'll get the quads and hams. And I'll talk about a prehab program in a second. But range of motion and flexibility exercises don't really much good, because what happens is the knee or the hip becomes so constricted that you can't get your range of motion back. So no matter how hard you force it, it's just not gonna go. So you're not gonna be able to improve it. Braces are not recommended. They offer no stability. A lot of people come in with instability in the knee or the hip, but more so the knee. Glucosamine, chondroitin sulfide, scratch it off the list. That doesn't work. Okay? If you want to try it, find it's a placebo. It may help, it may not, but probably not. Tylenol, acetaminophen, you can take up to 4 grams. And Celebrex actually is the best one to use because you can use it with aspirin, and it's very easy on the stomach. Now, I don't understand what's happening with the pharmaceutical companies, because Celebrex is off-label. It now has a generic. But actually, it's more the insurance companies, because it takes my staff just as long to get a Celebrex approved than a lot of other things. And if it's a generic medicine, you wouldn't think it'd be that big a deal. You'd think it'd be a very simple thing. But for some reason or another, insurance companies are hanging on to Celebrex. But that's the best one to take, especially if you have like heart disease and you're taking an aspirin, you can take Celebrex with that. Okay?
Why can't you take aspirin with the other NSAIDs?
Because they both inhibit platelet adhesion, and so there's more bleeding.
Oh, okay. It's just the increased bleeding.
Yes, sir. Yes, sir. So, corticosteroids or cortisone in the vernacular, that treats the soft tissue. And actually, it only gives you about a week, maybe 2 weeks of relief. And in an arthritic joint, it's not going to do an awful lot. If you're going to go to the Bahamas and you want to come out of the office and let us inject your knee, we can get you relief for about a week or 2, but after that, no use doing it, because remember, bone is not going to respond to a steroid injection. However, intra-articular, within the joint, hyaluronic acid injections may be effective, and that treats the hard tissue pain. Now, let's be perfectly honest. The American Academy of Orthopaedic Surgeons no longer recommends hyaluronic acid. In my belief, it's my belief that maybe 50% of the people will respond. And of those 50% of the people who respond, the response is almost always less than 6 months. There's some people who go longer, but it's not very often, it goes longer than that. So it's a short-term relief. So if you combine a steroid injection with hyaluronic acid, then you may be able to delay your surgery for a bit of time. Now, what is hyaluronic acid? Hyaluronic acid is a protein that our body uses to make synovial fluid. That's all it is. It's nothing dramatic. It's no magical bullet or anything. Okay? So those two forms of treatment are temporary. Nothing's permanent. The worst thing you can do to an arthritic knee is to scope it. When people say, I want an arthroscopic debris monitor, come in and clean up your knee, please, I'm begging you, don't do that. About 10, 12 years ago, I had a series of about 7 or 8 people come in and they said, Dan, we love you, but my knee is much worse off after you scoped my knee than before. There was a wonderful study that was done in the VA hospital, which is unfortunate because the VA patients have to wait for their care. But it did allow them to do this perfect study that was very, very convincing. And in our field, if you can get a level 1 study, which this was, it's a prospective, blinded study that was matched and controlled. They took a number of patients who went to surgery for arthritis, arthroscopic surgery, to their knee to clean them up, and they matched them with patients who waited, had to wait, and didn't get treated. The patients who did better were those who didn't get arthroscopic surgery, to a statistical significant amount. So that was a very, very important study. So I caution you, please don't get your knee scoped to kind of get it cleaned out. That doesn't work, it almost makes you worse. And the only time that I've ever done it is somebody who's in their early 50s, and they have a meniscal tear that causes mechanical pain. That's the reason why they have pain, is because this thing is blocking my knee. But in this age group, there's probably no indication for me to scope your knee whatsoever. Okay, because I can't take care of their arthritis. Arthroscopic surgery is a soft tissue procedure. It will not take care of their arthritis. Okay? That's a lot of information already. Questions?
What causes the popping?
Because the knee, the meniscus is now mobile. When it's torn, that piece of tissue will flip, and it will flip over, it causes popping, and it goes back, and it also can move in and out of the knee joint. The knee joint no longer is wide, now it's narrowed. And so when you walk on it, you push the meniscus out, and push it back in, and it will pop.
Because doing some of the prehab things, my knee pops, should I not do those? Or?
No.
Oh.
I mean, does it cause pain?
I'm on anti-inflammatories, so it doesn't.
Okay, so if it doesn't cause pain, I would continue to do strengthening. I definitely would. But yeah, that's not a need that I would start. If it caused, every time you had a pop and it caused pain, so okay.
Oh, no, I was popping out of that, that topic into just having a knee that pops.
No.
Is that the same popping you're talking about there?
No, it's not.
Oh.
Most of the times when a knee pops, it's usually a piece of loose cartilage or a piece of synovium that's been chronically inflamed and now has become hardened. That can cause popping sensation. We call that trepidance, and that's usually a soft tissue phenomenon. We don't go after that because you probably need to get your knee done. If you have a lot of that, then it's going to be.
Well, I'm on your schedule for
okay.
this knee, but I'm thinking
I kind of
about
figured you
the
were.
other one.
All right. Anything else? Yes, ma'am.
About 4 or 5 years ago, AARP in their magazine put out the 4 or 5, 10, whatever it was, surgeries old people should not have, and one of them on it was arthroscopic surgery.
Yeah, absolutely. Yeah, I think, there should be a big ban for arthroscopic surgery in the older patient. Yes, ma'am.
And what causes fluid in the knee?
Well, what happens when you get that synovitis, what it does is the synovium will secrete more fluid to try and keep up with the disease.
Okay.
And it just can't keep up. And so it tends to accumulate because now the drain, the other kind of cells that gets rid of the fluid and the debris in your knee gets plugged up. So now the fluid will start to accumulate. Because you make more and you can't drain it. Okay. Yes, ma'am.
Sometimes people get partial knee replacements and partial hips. Who gets, what's the deal with partial versus full?
That's a very good question. I might as well talk about it now. Okay, so if you have isolated medial tibial femoral compartment on the inside part of your knee, if it's pure medial compartment, you probably would qualify for a partial knee replacement. If you have 5 compartments, there's 3 compartments in the knee. The patellofemoral joint compartment, the lateral compartment, and the medial compartment. If you have medial compartment isolated disease, you would be eligible for a partial knee. If you have patellofemoral joint disease, then you probably should not get a partial knee replacement because there's a phenomenon called referred pain. So let's just say you've got arthritis in the patellofemoral joint and your surgeon chooses not to pay attention to that, or he says, well, that you're going to be okay with that. If you have your partial knee replacement and you still have pain afterwards, you don't know whether it's a complication from the surgery itself or it's referred pain from the patellofemoral joint. You just don't know. You will never know. Okay, so if you have patellofemoral joint, do not get a partial knee replacement.
If you have what?
Patellofemoral joint, kneecap area of pain. Now, people will say, well, what if you do the lateral compartment? You have just isolated lateral compartment. The lateral compartment, the performance, the ability to do a lateral partial knee replacement is very, very difficult to do. Very few people do them because you can't get the kneecap out of the way. And maybe you can do it with the Mako, with the computer, but even that, it's just really hard to get to the knee. It's very, very difficult. So that's the indications. Now, the other kind of soft contraindication is if everybody in this room, for the most part, wants longevity out of their implant. It's predictable that you can get 20 plus years out of a well-done total knee. Clearly, that's not a problem these days. With a partial knee, it's not going to give you 20. You may get 10. If you're really, really, really lucky, you'll get 12. And then you're going to come back and we're going to convert it to a total knee. So it depends on how many times you want to go to surgery. Now you do recover fairly quickly with a partial, but not everybody does. Okay. Does that answer your question?
Yes.
Okay. All right.
Well,
Anything else? Okay.
I don't know what's wrong with mine. I had, a knee x-ray, and it said I have, minor arthritis.
Minor arthritis?
It said minor arthritis was in my knee.
Okay, that's a very good point, and that's actually an excellent point, because sometimes, talking about referred pain, oftentimes you get referred pain from the hip to the knee.
Then I had it at my hip, and then I had an x-ray my hip, and they said I had, minor arthritis in my hip.
Okay, if you have a hip arthritis and knee arthritis on the same side, then you have to really make sure, first of all, you gotta make sure it's not the back. Okay, first
I ain't got nothing in the day.
Okay, first of all, you gotta make sure it's not the back. And then you look at the hip and you make sure that the hip is not the problem. You can do a diagnostic therapeutic hip injection to see if it gets rid of the pain in any way, shape, or form.
The doctor gave me a cortisone shot in my knee, but that ain't really help.
No, it's probably not going to help.
And so he's been giving me some pills, but the pills really, it's like sometimes the pills just carry the pain or the aching feeling away for a while.
Well,
And then the Tylenol do the same thing, it carries it away for a while. But then my hip and my knee still hurt, cause it goes down in the leg when I walk, and sometimes the leg will pucker up on top.
the most important thing is, again, because the pain goes below the level of the knee, you really have to be concerned about the back. You really, truly have to be concerned about the back. You've got to make darn sure your back has been ruled out as the source of pain.
I don't
Clearly.
have no pain in the back.
Oh no, you won't have any, you don't have to have pain in the back. No, you can have nerve root pain below the level of the knee and have no back pain.
And in the hip too?
You gotta make sure it's not your back. If you haven't had a radiographic evaluation, probably to include an MRI, then you don't know the answer to your question.
Okay, I probably need an MRI.
Yes, indeed. I would definitely rule out the back, rule out the spine. Okay, because that pain goes below the level of the knee, that's usually nerve root pain. That is not hip pain. That is the only time knee pain goes below the level of the knee is when you have your knee so diseased that when you strike your heel on it, when you walk, the energy comes up through the tibia, hits that hard bone in your knee and ricochets back down. But that's always in the front of the knee.
And I know when
Not
I
bad.
walk sometimes, you know, I do a lot of moving around. Sometimes it will pop up, my meat will pop up.
That sounds like either an L2-3 disc or a hip.
Or what?
It's either an L2-3 disc problem, nerve root problem, at the level of L2, L3, like a high disc, or it could be from your hip, referred pain from your hip.
Pain from my hip.
Or it
I
could
said
be,
the hip be like, the hip like, you know, be achy around and here, it's like sore, like, you know.
Well, I think first of all, when you see somebody, make sure they look, again, you gotta make sure it's not the back, and then you look at the hip. And there's ways that you can do diagnostic. Somebody's gotta examine your hip to make sure.
Yeah, I had to have a MRI, right?
Yep. Yes, ma'am.
If you've been told that a partial replacement will do the trick, can you tell that on a regular X-ray, or do you have to have an MRI?
You should probably tell that on an MRI. I'm sorry, I can tell it on plain film. If you've got, the other thing too is you cannot have a big varus deformity when you have your arthritis. If you come in and your knee is like you're bow-legged, you're not going to get a good result out of that because you cannot change varus deformity with a partial knee replacement like you can with a total knee. With a total knee, you can correct the deformity. You cannot correct the deformity with a partial. Okay, so be careful with doing too big a deformity. That's another reason not to get one. Okay, so people talk about platelet-rich plasma. It's the first time I talked about this. Think about it, the healing growth factors are on the human platelet and are necessary because of the healing. So what we do is we take a sample of your blood and we centrifuge it and we separate the plasma from the blood. Is everybody familiar with this? Does everybody know what I'm talking about? Okay. Now, PRP growth signals do not recruit stem cells. Okay, that's very important to remember. So if you take PRP and you inject it in the knee, it ain't gonna do anything for you. You're gonna waste your $500. Go get a nice bottle of bourbon or something. Don't get PRP in your knee. It's not gonna do anything because it's not gonna bring in the stem cells that you need to repair the cartilage or the bone. Okay? Don't do it. Now, if you want it for lateral condylitis, if you want to do it for other sorts of ailments or whatever, fine. But specifically for the hip or the knee, don't do PRP because it's not doing this. That's key. So, what about mesenchymal stem cells? Okay, they're isolated. You can isolate it from the bone marrow aspirate, and they are thought to be multipotent cells. Okay, and these cells maybe people don't think about. Okay, what if all of a sudden you get the cell line in you and then it differentiates into another cell? Or what if it gets going and you can't turn it off? Okay? So think of this treatment as planting seeds into a damaged tissue. So say you want to take some of these mesenchymal cells, these new cells that they have, they're immature cells, and you stick them in cartilage. Well, remember, cartilage doesn't have blood supply. So there's no way to keep it going. It's just not going to work. Same thing, and if you remember what I said before, how hard that bone is. I mean, sometimes you can get some cartilage to cover it, but that's the best you can do. You're not going to solve the problem. So be cautious about spending thousands of dollars for mesenchymal stem cell treatment. Okay? I'm not saying don't do it. There's not enough science, there's not enough clinical application in my mind to make it a viable treatment option in a very practical manner. Maybe you've heard of somebody that did better with it, whatever, but those guys have a lot of money in the bank and they can afford to lose $10,000 and see if it works or not. Personally, I'm not sure that's really the right way to go. There's just not enough science to prove that it's the right way. Okay? All right. Any questions on those two slides? All right. I'm not saying, they can investigate it, but from what we can tell, actually, before I gave this talk tonight, I went to go look at the Journal of Orthoplasty, which is the journal for the American Association of Hip and Knee Surgeons that I'm a member of. And there weren't any articles in there that talked about treatment with mesenchymal stem cells. Okay? And that's the premier journal for American orthopedic surgeons who are doing this. So, this is important because now we're moving into an arena where we have to be very careful about what we do. I would say 10 years ago, as an orthopedic surgeon, when we did a total knee, and we just schedule a total knee, you get a blood, and you get a heart, and boom, you go, and don't even think about it. Now, it's a completely different environment. Particularly here, since we've been here, it's a really nice way that we have developed a program to make it very safe. And these are clearly red lines. If you don't have a hemoglobin of over 10, which is a blood volume measurement, you're not going to surgery. Today, we canceled a bilateral total knee because their hemoglobin was 12.8. So she said, well, do my left knee. So we did our left knee, but we didn't do our right knee. I have to be safe. You have to have enough energy to recover, to do the rehab. If you don't have the oxygen carrying capacity, you're just not going to do well, okay? Hemoglobin A1C. If you're diabetic and your hemoglobin A1C is not less than 7, you're not going to surgery. It just will not happen. That is the parameter where we look to see diabetics, as everybody probably knows, has an increased risk of infection. So we got to make it as safe as possible. So if your hemoglobin A1C is less than 7, you're not going to surgery. You've got to wait at least another 3 months, right, before you get your next hemoglobin A1C. Make sure sugar's under 120. But this 120 is for everybody. That's for everybody, whether you're diabetic or not. We like to keep it under 120 in the perioperative region because regardless whether you're diabetic or not, if your sugars go up, you still can feed the bacteria, right? So it's the sugar. Okay, this is very recent. The red line of a BMI of less than 40 has become a reality. Okay, canceled a case last week with a lady who had a little bit high BMI. She's really upset. She got all angry. I said, and we kind of talked about that. You know, we thought we were going to lose some weight. Here's what we know. We know that people who try to lose weight to get under the 40s oftentimes doesn't happen because they say, well, if you do my knee or you do my hip, I'll go exercise. Well, those studies have been done too, and most people don't lose the weight after you do the hip and the knee. There is definitely clearly an increased risk of infection with the BMI over 40. Now, I don't think it is as important for total hips, but I will tell you for total knees, it is absolutely important. Because here's what happens. You touch the front of your knee, you can feel your kneecap right underneath your skin. With those people who have a BMI greater than 40, here's what happens. You make that incision on the front of your knee, then you go through a layer of fat, and now you're on the kneecap. Well, that layer of fat, when it was cut, has now become necrosed. It's dead because something cut through it, either electricity or what we use is argon gas. Now, you have the incision, you repair everything back up, and now a bacteria gets through some break in the incision and infiltrates and sets up shop in that fat. That fat gets infected, you get a little bit of drainage, and it goes into the knee because now there's another incision to get into the knee. That's how I think this comes to be. So when I see somebody, even if you're in the BMI, that's good, I worry about fat between the skin and the top of the kneecap. It's a very easy way to see who's going to be at risk and who's not. Okay? All right. Does that make sense?
Yes.
Okay. Very quickly, tranexamic acid. Our transfusion rate is probably 0.5%, and you don't want to lose your blood. I would say on a knee, we lose about 100 cc's, which isn't this 2 big syringes, which is hardly anything at all. It's not going to move your hemoglobin. And the hips we lose about maybe 200, maybe 250, because it's just a lot more soft tissue to get through. So the tranexamic acid, what it does is it doesn't let the clot get dissolved. It keeps the clot there so you don't bleed. That's a very important medicine. Most people use it now. We don't use drains anymore. We haven't used drains in years because actually what I thought the drains did was just suck more blood out of your knee or your hip. So that doesn't make any sense. And it's also a runway for bacteria to get into the knee or to the hip. Okay. MRSA, the dreaded MRSA, that is kind of such a bad actor. But I will say, Centera, in this particular city, Williamsburg, Centera, is a very clean hospital. There is no knife and gun club. There's not. So that stuff isn't carried upstairs. It's just, and we are very strict. If we do not allow infected anything on the orthopedic floor at all. It's just not allowed. So we really keep it isolated. Somebody comes in with a cold, and then we'll either go to another floor or way on the other side, on the opposite side from us. But we do this, if you have MRSA, there's an increased risk of infection, so everybody gets treated. You get a certain medicine we use, and so when you come to surgery, we check for your MRSA status. If you've had it and treated, you go. If you're negative, you go. So that's another thing that we really, and we also included MSSA too. Now we use that now too, so we cover both of them. And of course, all the pre-surgical scrubs are mandatory. This is what I call the philosophical age of 75. Although I will tell you, like today we did an 80-year-old knee, when we did a 78-year-old hip. We do a lot of folks. The average age of the population that we did last year was 69. Yeah. And you know what? Those 69-year-old folks, they're the best patients to operate on. They are the best, because number one, they pay attention. Number two, they comply. And number three, they're not trained to run a marathon. They just don't want to have the pain and have enough motion to do what it is they want to do. So I would say 65 to 80, 81, great population. 45, I hate operating on those guys because they still want. I just did a hip the other day, and the 48-year-old lady says, "So when can I start skiing again?" I said, "We have to start." You know, there's not because they don't think like us. They don't think like me. You know, I mean, I'm not 45 anymore, so I don't expect to do what 45-year-old people do. So as we get older, you know, it's easier because the expectations are less. But nevertheless, we do know, if you review the literature, that if you're over 75, there's an increased risk for cardiopulmonary disease. So heart and lung issues. So we've got to take care of these people. So we cross all our T's and dot all our I's. And so we're very careful about getting these people in. And I do tend to hold them an extra day. They don't get the option of going home the next day, typically. Except the hips. If the hips are doing well, I let them go. With the knees, I tend not to let them go home the next day. Okay. But surgery is very successful in the mature patient. Very successful. They do very, very well. And just for total knee replacement, the goal of pain management is not to get your pain to 0/10. That's not what we're trying to do. We're trying to get your pain down sufficiently so you can successfully complete a course of physical therapy. So we use an adductor nerve block and we use Exparel. These two combined modalities will give, if we do you on a Tuesday, then you should feel pretty good until Thursday morning. And then you're going to rebound. Not everybody rebounds a lot because the inflammation is leaving the body. More inflammation, more pain. So by Thursday morning, people feel pretty good. Some people want to go home on Wednesday. Tuesday's not a big day. That's the only reason why I use Tuesday. But when we put the adductor nerve block, it lasts about 8 to 10 hours. So the whole front of the knee and the front of the thigh is pretty well taken care of. And then during surgery, we inject something called Exparel. And Exparel is a long-acting bupivacaine in these little spheres that pop when they see fat. It takes about 8 hours to set up. And we inject that in the back of the knee because the adductor nerve just gets the front of the knee, okay? So we got front and back. And so we can get you feeling pretty comfortable in physical therapy for Tuesday, because you will be walking the day of surgery. The day of surgery, you'll be walking, okay? So less post-op pain. We use a lot less narcotics. As of 3 months ago, we stopped using IV narcotics completely. There's no more IV narcotics. Now we can use IV Toradol, which is a non-steroidal inflammatory agent, but they have to call me for an IV narcotic. I'm not talking fractures, I'm talking total joint, total hips. Fractures are different. Okay, Exparel, we kind of went over that. Hybrid plasma scalpel. This uses argon gas, and this is the key thing right here. It burns at the depth of 0.2 millimeters versus 4. So again, if I'm not causing necrosis, I'm not causing inflammation. I'm not causing inflammation, I'm not causing pain. And that is a big, big advantage compared to using electricity. And when I use argon gas, I don't use a tourniquet anymore. We haven't used a tourniquet in a long time, okay? So argon gas really gives very good hemostasis. Again, only 100 cc's without using a tourniquet. No tourniquet, okay? And this has been shown post-op swelling, less quadriceps pain. We want you to get up. We're gonna have you walk on the day of surgery. We're not gonna put any impediments in your way. We're not gonna block you from doing that. That's why we change.
Walk the same day of the surgery?
Yes, ma'am.
You did the surgery?
They all walk the same day.
Oh, that sounds good.
Yeah, because you're going home the next day, a lot of time. The hips, a lot different than the knees, okay? But everybody walks the same day.
And you can do the hip too and the knee?
Same day.
Oh, okay.
Now, so how do we take care of the incision? No staples, we use skin glue, no drains. We started this about, I don't know, maybe almost a year ago, I think. And what we do, the thought is that I got a patient who came back to me where her cat licked her incision, she got infected. So I said, oh, I can't believe it. So what we did is went to the 7-day dressing, we call it the honeycomb dressing. We put it on at the time of surgery in the OR. Nobody touches it for 7 days. And so whoever's blowing their nose isn't changing it, and no animals licking it. And you can shower the 2nd day after surgery, so you can shower with this dressing. And the good thing about it is you can see the incision. A lot of people use what we call a Mepilex dressing, which is this brown dressing, but it's opaque, you can't see, so you have to take it off to see what's underneath. But with the honeycomb dressing, you can see the incision. And since we use skin glue, we feel that by the 7th, 8th, or 9th day, it's completely healed, you know, it's closed, it's sealed, and you can take it off. A lot of folks will come back to
You
the,
don't shower on it
yeah, you can.
till the 2nd day, right?
Well, you're in the hospital the 1st day, 2nd day, you can take a shower. It's beautiful. It's a great dressing. It only costs $7. So, cheaper than the Mepilex. So, now this is the thing we kind of started to, another good thing we got to, so let's say you're at home and you say, you know what, Dan, I don't know, I'm not liking the way my wound looks. They say, well, okay, take a picture of it and send it to me. I can tell you to come in today, come in tomorrow, what we can do, and the kids can make a distribution or, you know, some sort of idea what we want to do, okay? So it's another way.
Do when they go home like that, you have to give them anything for pain?
Very little. No, we can take it. But that's an interesting, because now everybody's aware of the opioid problem in America. So now the new Commonwealth law as the 1st of July, I can only prescribe narcotics, including tramadol, for 2 weeks if you're non-surgical, and for a surgical patient, only 2 months. Cannot be renewed. So that was a good question. Let's go through these because these are too technical. Well, we're not really necessary. So this is what I call, this is the mechanical axis. So you draw a line from the center of the hip to the center of the knee to the center of the ankle. There's several studies that it shows that if you can reproduce that, that one variable goes a long way to get that knee last for 20 years. Right? So you get that 0 degree. And we use a computer to do that for us in surgery. Yes, sir.
If you take a picture to see what it is that you mentioned, bow-legged, you know, some of it's bow-legged.
That's a very good point. We do not, but I would say probably, probably the last 1,000 knees, I've changed it once. Sometimes you look at something like, no, you look at something, really? And then when you make the cut, and it works. I would say probably the last 1,000 knees, I think I've changed it once. Okay, that really looked kind of weird. It's very, very, very accurate. And that's what we try to do to get that knee, that whole mechanical axis to go to 0. That's 20 years. Again, we use image guidance to do that. You may have heard about Makoplasty, the robot. I just do this light up here because call the hospital and tell them I need one. Because this year, before this year, you could not do a total knee with the Makoplasty, with the robot. You could only do a partial knee That includes either the patellofemoral joint or the medial compartment, unit compartment, or the partial knee. You could not do a total knee. This is the first year where a surgeon can use a robot to do a total knee. So I've seen a demonstration of it, and it really is, and this is the older style. The one with the total knee actually has a blade on it. And they say, I mean, when I went to this course, I went to this demonstration, they had all this stuff up there, and they teach you how to do all that, and then they give you the blade, and it's like, boom, 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 good, thank you very much, have a good day. I mean, it's, I don't know if it's the end all, the be all, but I do know that they're not gonna do it down in Newport News. There is a guy up in Richmond's gonna get it, a guy down in Virginia Beach is gonna get it, but I think this would probably be a good place, so I'm gonna spend all my political capital to get a robot. So that's where I'm headed. When you look at it, I think the most important thing is, you know, with the human eye and when I credit the system, we can still only recreate mechanical axis, but with a robot, you can do the kinematics. So your knee will work so well like it did before. It will recreate your knee before you had the disease, the way it worked, which is, we can't do that today with the standard knee replacement. I mean, you get really, really, really close, but this really duplicates your own kinematics of your knee. And when you're tight, when you're not tight, so everybody didn't realize that everybody's knee is different, functions differently. Generally the same, but there's enough difference that it makes your knee function unique.
When you do the robotic method.
When?
You do the robotic method.
Well, I don't have one, but I'm trying to convince the hospital that we really need it. so I'm not sure I'm even halfway there, but I threw it in because it's new. It's probably a very good idea. It's not going to save us any time. It's just going to make the individual patient, I think, function better. There used to be a system called ISMAM.
How much is the machine?
Close to $1 million. I can get it on this. I think they can give it to me for $750, but that's still a lot of money. But I've done enough joints here. Like I think we can probably pay for one. This is just to show you that this is another idea about why we are where we are today with total knees and total hips. Everybody's using highly cross-linked polyethylene. It's a piece of plastic you went on the back table. It's triple cross-linked. Stryker was the first company to come out with triple cross-linked polyethylene. That the plastic between the two pieces of metal used to be the weak link. You need to have poly wear all over the place, and these would fail pretty easily. But now, you know, all these companies have solved that problem. If you use, you can use metal. Do not use metal on metal. Everybody knows about that, right? I mean, that's hundreds of millions of dollars going in people's pockets because people use metal on metal. Ceramic on ceramic is a very good system, very hard, very well functioning until it squeaks. Ceramic on ceramic can't squeak. If it squeaks, it's an automatic revision because you're not going to like the squeakiness. It's really inaudible, painful. It's not painful, but it's like, oh my God, this is very irritating. So polyethylene, and when Joel Mata out in California talked about a small incision surgery, and now when I do a direct total hip, when I do a DA hip, the incision is the width of my 4 fingers and in front. That's it. That's all I have. That's all I need to do. That's all the space I need to do a total hip in the front, and then go home the same day, next day.
How long does a surgery take, like a total knee replacement, typically?
45 minutes, and today we did a hip in 30 minutes. 30 minutes, 30 to 35 minutes. If I have a team, I have today. And I almost always have them because I get a little upset when those kids aren't in my own.
So how many total knee replacements have you done?
Thousands. I can't even imagine. I've been doing a direct total hip for 13 years now. The ratio is about 3 to 1 for every, maybe 4 to 1 for every 4 knees I do a hip. This is kind of just basically saying that the public, this is what the public wanted. I mean, they want a small incision. I want a small incision because I want to be able to get you moving and get you back to where you were before. I mean, if you're younger, you want to get back and produce income. If you're older, you don't want to be lying around. You don't want to be rehabbing from a total hip or a total knee. I mean, I'm on borrowed time. I got more past than I do futures, so I don't want to be spending a lot of time getting through this. Now, this guy, John Keggy, he's from Connecticut. Back in 2003, okay, he reported on 2,132 hips. When I was training in Connecticut, we thought the guy was an idiot. They said, are you serious? Nobody does a direct anterior hip. But he's the guy who really should be acknowledged as being the pioneer for the direct anterior hip. Some people call him the Jiffy hip. This is the fella who, again, 2003, he reported on over 2,000 joints. And these are his results. There's only 7 PEs, 0.03 infections, and 28 dislocations. And a lot of people have adopted it, but it's not common. Okay? Most orthopedic surgeons do not do a DA hip. Most still go either posterior or anterolateral. Okay? So like I said, we've done it for about 12 years now, and we see those kinds of numbers. For example, since last 12, 13 years, we've had several thousand, we've had 2 dislocations. 2. So, the DA approach, what is it? I mean, what it is you do not, let me go to this next slide. So here it is, 8 centimeters, 4 inches, okay? So the head's over here, the midline's over here, is outside the leg, and here's the bottom, the foot's down there, and there's the incision right there, 8 centimeters. So it sits right over here. So what we do is you make this incision in front of your hip, and it sits right about here on a normal anatomy. And then we make the neck cut, take out the head. Then we make the acetam ready to accept a cup. And then we have a special table called a hammer table, and it externally rotates and moves the hip out and down so I can get in the canal, and we put a stem in. Okay? And we put a ceramic ball inside a plastic cup. So it's a titanium sandwich, titanium stem, titanium cup with a plastic liner and a ceramic head. 30-35 minutes. Just really, really move.
After about 25 years, when it starts to sort of wear out, is it basically the mechanics that wears out, or the tissue around the bone around it?
It usually will become, it could be, at 25 years it could be either be the plastic or it could loosen. But the stem hardly ever loosens. If you're going to loosen, it's going to be the cup. And we've done a revision through the front. So you go through the same incision, pop out the cup, not exactly like that. Take out the cup, and then put a new cup in, and put in a new stem, and put in a new head ball, and you're good to go. That takes us more than 45 minutes. But yeah, you can do a revision through the front too. I'd say it's very uncommon that we take out the stem. Very uncommon. That's usually like a rock. So that's it. So this is the guy who decided he wanted both at the same time. And this is how, when we're in surgery, the reason why I drew this picture is because everybody has this anatomy. And when we do a DA hip, you're lying on your back on the table. And I have this point here and this point here. And as everybody knows, you have 2 points you can draw a line. So I draw this line here across this. First we did this hip before we did this one. And then so we measured, see this is the lesser trochanter right here, these little pieces of bone. So we reposition your legs so that we can see those pieces of bone. And then we line them up. And you can see it hit that lesser troch and about the same point hits that one. That tells me those leg lengths are within 2 millimeters. Okay. We do that on every single hip. Question? You look perplexed. You're not believing this. Yeah, it's really, I mean, and even then it's not perfect all the time, but overwhelming vast majority of the time, your leg length discrepancy is a couple, 2 or 3 millimeters. Okay? That's easy to understand, right? Okay. And these are the cups we use. That's pretty easy. So here's the titanium cup. This is a different kind. This is a dual mobility. That means you got this big ball. For people, the reason I put this on is because people say, well, metal, why do people use metal on metal? Because people use metal on metal because you use bigger balls. When you have bigger balls, then you can't dislocate. So it tremendously adds to the stability of the construct of the total hip. Huge. So what Stryker did was they got to say, well, okay, well, you can't use metal on metal because we're going to go to court. So we put this in here, and they put a metal liner in there, and then they used a big ceramic ball. Huge ball. I mean, this thing is 40, 42, 44, 46 millimeters. And then they put this 28 millimeter ceramic ball inside that. Very stable. Very, very stable.
Ceramic is better?
I think ceramic on polyethylene is the best combination of surfaces. Ceramic on ceramic, there's a chance you squeak, and if you squeak, you're not gonna like it. You're really not gonna like it. And that's what it's like to put all put together. So physical therapy. Physical therapy has taken the front seat in the management of total hips and total knees. More so total knees than total hips. I think now, the techniques that we have, the implants that we have, that's not gonna change by much. There's no new product out there that's gonna redesign or reinvent or improve dramatically total hips and total knees. Those implants are already designed. This is what makes the difference, okay? We have group therapy at Centera in Williamsburg. And in my opinion, at first I thought I would poo-poo this, that doesn't make any sense. But when you see that group of people in there, and they're looking to their left and they're looking to the right, they're saying, I'm gonna pick up the pace, and I'm not gonna get left behind. It's really an amazing encouragement to everybody, and you get to know people, and then you go to lunch together, and you go take a break, and then you come back and you do it again, okay? And it really moves people, and so within one day, total knees, we never got this before. We never got 100 degrees of motion on the first post-op day. Just didn't. And they basically go straight. Every now and then maybe 2 or 3 degrees. But that's amazing that we can get that. And in total hips, those guys walk in and walk out, I'm out of here. They'll walk 300 feet in the first day or the next day, and then they walk out the door, they do little steps, then they're gone. They're gone, they're out the door. Okay, put on your makeup, goodbye.
They'll be complaining that you're through and not.
I beg your pardon?
They'll be complaining that you're through and
No, I mean, a total hip. Okay, like we did a gentleman this morning, 7:30 this morning. He's off the table by the time I did my part, they did their part. He was in the recovery, he was upstairs at 9 o'clock. I saw him at 1 o'clock, having him taking the pain medicine. I was like, a little bit of pain. He said, can I go home tomorrow? I said, yeah, you can go home tomorrow. He's 80 years old. Skilled nursing facilities. Probably another year or so, no more, okay? Last year, we sent 84% of our patients home. We're trying to get that to closer to 95% of patients going home. That causes a problem if you don't have somebody to take care of you, son, daughter, spouse, whatever, friend. And what a lot of people are doing across the country is that they are actually having the coach sign a letter of commitment. I don't think I have to do that yet, but the whole emphasis is do not go to skilled nursing facilities because it's where I get most of our readmissions. Now, to most people, they may not know what the implication is, but if a hospital gets too high of a readmission rate, they lose money. If I get too many readmissions rate, I'm going to be taking off panels. Okay? I got a readmission charge last year. I didn't realize it, but I did a total knee. It's 30 days. For any reason, if you get the total knee and you get readmitted because of you have like chest pain or you have diarrhea, and you go back in the hospital and get readmitted, I take the hit. Doesn't matter what it is.
That's not right.
I don't think so either, but the rules. The only two reasons why you can't is if you have cancer or if you're in a major trauma. But otherwise, the surgeon gets the hit and the hospital. Okay?
Do you get a lot of?
Oh, I absolutely get a letter.
Nursing facilities?
I get a letter from the Department of Medicare, whatever it is, whatever they call themselves, Medicaid, Medicare. I get a letter saying, thank you very much. I didn't realize now, as of January, it went from 30 days to 90 days.
Oh.
I know, so we just can't clear them. We really clear these patients, but sometimes something happens and they just get readmitted. But I will tell you, there's a game to play, and it's a double-edged sword. So let's just say this gentleman here, I do his total knee, and he comes back in, he's got a little rectal bleeding, and he gets admitted. I take the hit. But what if I come in and say, can you put him on observation? Which is not an admission, but you go to observation. You can go to observation for 2 days.
If the Medicare won't pay for it.
Thank you, doctor.
We know that trick.
So that's the problem. See, Medicare is always saying stuff ahead of us. So because they knew that we figured out how to rig the system, because they rigged it against us. But now they got this law, so you just cannot win. You cannot win with Medicare. So we really, what happens, quite frankly, is you got a husband and, you know, and a spouse, or a man and wife, or a friend or whatever, and they say, you know, they call me and say, you know, my wound doesn't look good. Send me a picture. Don't go to the ED, call me, or call the office. We wanna know what's going on. The guys at the nursing facilities, they don't call anybody. They just pack you up with an ambulance and take you to the ED. Now they gotta deal with it, okay? So that's why that happens, and it's a national metric. Every single hospital that does total knees and total hips. What's gonna happen, if your readmissions are too high, you're not gonna be doing total joints at all, at all. Low volume people, those hospitals, dead. They're not gonna be doing them anymore, because you can't keep it up. Yes, ma'am.